आज किया ना तूने?
क्या सर?
आज हाफ डे किया ना?
आज हाफ डे किया। चिंता हो गया था मुझे आप लोगों को पढ़ाने के चक्कर में।
नहीं, all our fellows are knows there. Manoj has not joined. हम start करेंगे.
Yes sir.
Good. So just to let everyone know, Ankit is a very good friend of ours, and Ankit has done pediatric critical care DM from PGI. हम दोनों ने काफी काम किया है, मस्ती किया है, सब कुछ किया है, and he is a very good teacher and enthusiastic runner. ठीक है? So let's start this very interesting session, extubation protocol, or how to go ahead with the extubation. Everybody is there listening? Good.
Yes, sir.
Oh.
And all the questions we'll take it at the end. Ankit will also say the same thing, and we'll discuss about it.
Correct. So, good evening, one and all. I hope I am audible.
Yes, yes, you are audible nicely.
Correct. Okay, thank you. So, thank you so much, sir, and welcome all of you. My first thing is that whatever we are going to speak, it may not be something which you might not have heard of, but it is the way you do it. So it is about how you prepare yourself to extubate a child. So first of all, we all know that intubation and extubation of a ventilated patients, these are not easy things. And we all know that it is not risk-free. It is one of the things which is very difficult in intensive care. And we always discuss whether we should intubate or not. What are the advantages of being intubating this child? And once you intubate a child, we all know that there is a significant amount of morbidity and mortality associated with a given patient. So in a given scenario, extubation may even fail around 10% of the time. And number, obviously, as the extubation number increases in a given unit, the failure, there are also associated number of risk of like morbidity and mortality along with that. So if you go towards like what is a smooth way of doing it? So a smooth way of is that you do a given task in a way that there's someone who is looking at this procedure may not even understand that how difficult it was. So maybe when we see our seniors, we see our consultants, when they take decisions, some of the time, we just feel, oh, it was so easy that we have done it. But let me very clarify you, if you don't know the process of how to probably wean a child from or liberate a child from mechanical ventilation, it might sometimes be very not a good overall decision making, can really give a bad outcome. So when I tell you bad outcome, so anyone, can you tell me like what can happen if you prematurely maybe extubate a child? Like what are the things you have seen in your intensive care unit if you prematurely extubate a child? Any one of you, you may just unmute and like maybe tell. That's okay. So obviously that's fine. If you
Higher chances of
reintubation is there.
okay, okay. And anything else? So obviously the number of days of ICU may increase, correct? Okay. Anything else which is very, very important? If somebody has read a very good paper which was published maybe like years back. So this was the chart if somebody has seen. Anyone? So this is a very good chart which tells you that why it is important for an intensivist to understand that we should not have premature extubation. So you look at this, like the reintubation rates, which are given in the box, which is not colored, which is the white box. And if you look at the reintubation rate of the different ICUs, which was around 15%, around approximately. But look at the ICU mortality of the patients who were reintubated, and these are all pediatric ICU patients. So you can see the number of risk, it is almost in some of the studies, it is 50%, and it may be as less as around 25 to 27%, which is around 1/4 of your children are dying if you are probably prematurely extubating them, or maybe they are requiring a reintubation. All of them is the same thing. So obviously it is the high rate of ventilator associated pneumonia if you prematurely extubate them. You might also have increased mortality. You can also have risk of aspirations. So there are a number of things which can happen. And that's why I'm taking your class, that how do you wean and why do we care that weaning is such an important thing. So 40% of the children obviously require mechanical ventilation in our ICUs, and 40% of them require mechanical ventilation over 48 hours. And weaning accounts for around 40% of the duration of mechanical ventilation, which is a very big number. And if you don't take care of this number, this 40% of the duration may also increase. And as we all told that most of these extubations sometimes are probably they are not planned, or they are not successful because of some or the other thing, which we are going to look into this probably lecture today. So my learning objectives will be, what should be your extubation path of a child who is on mechanical ventilator, and what should be your extubation checklist. So I make it a point from senior residency that every patient who is getting extubated should have at least an extubation checklist, that whether we are correct or not in extubating a child. Okay, so this I think everybody must have seen. If you have not seen, probably you should all remember this chart, which is the most important chart probably. So if you intubate a child, as soon as you intubate and you start a mechanical ventilation, you should know that why I have intubated a given patient, why I have put them on a mechanical ventilation, what are my goals, and what is the process, what is the timeline where this process is going to end. Probably you have intubated a traumatic brain injury, which is a moderate to severe traumatic injury. You might require a ventilation for 10 to 21 days. You might have intubated a pneumonia, simple community acquired pneumonia, which may require a ventilation anywhere between 3 to 5 days. And probably you might have intubated a scrub typhus, which might require an intubation or ventilation for 7 days. So first of all, you should be very clear in your timeline that what is going to happen. I'm not telling that every child will follow the same path, but at least once you intubate and mechanically ventilate, you should know that this is the timeline I'm expecting for a patient to recover. So as soon as you intubate, you should start thinking about that what will be my plan for weaning such a child. Okay, so the first is intubating. Second is obviously onset of weaning. And as we have already discussed, this course of weaning almost takes 40 to 50% of the child on mechanical ventilator. And once there is an end of weaning, then you might thinking about liberating a patient probably from the mechanical ventilation, which might be the extubation. So what is the weaning? It is the spontaneous breathing which starts on a mechanical ventilator. And when does it end? When the patient is completely on his spontaneous breathing on mechanical ventilator. And then you think about extubating a given child or liberating it from the mechanical ventilator. And once they get reintubated within 24 to 48 hours, some of the studies even take it as late as 96 hours, that it can be taken as a weaning failure. So these are the charts which we are going to discuss today. So my first point is, which is very, very important. What do you do during the initial 72 hours or first 4 or 5 days of mechanical ventilation? Second is, we are going to discuss about what happens during when you start weaning preparedness. Third, we are going to discuss about what do you do peri-extubation period. And fourth is what we can do to prevent a reintubation. So the first thing what we are going to discuss is, now let me be very clear. Like I have put a few of the quotes that whatever you do, you have to do it well. That is what you have to understand. So if you intubate and mechanically ventilate a given child, you should know that you are using all the basic things like a good sedation, good analgesia, you are using a lung protective ventilation, you are using a proper ventilator associated pneumonia bundle, you are taking care of a patient who is not having significant synchrony, because all of this can lead to significant lung injury over a period of time, and that can increase your mechanical ventilation duration. Now, two things which I have highlighted here is most important, which are very, very important as an intensivist, is cumulative fluid balance of first maybe 72 hours, which is very important. And what is the sedation? How do you go about it? Which is very important. And it has to be protocolized in every given ICU, that this is the sedation scale which we are going to use. And this is the sedation we want in a given patient. Obviously, we are not going into the details that what happens if you over sedate and under sedate a child. But the most important thing is sedation level has to be discussed in a given patient. So this is a very simple study. All of us already know that any amount of fluid overload, especially if it is more than 10% in a given patient on a given day, it can definitely increase your risk of organ injuries, and it can also lead to increase in the oxygenation index of a given patient, and definitely increased fluid overload leads to prolonged mechanical ventilation and a poor outcome. So your fluid status has to be checked if in an intensive care at least every 6-hourly basis. And I would suggest you, as soon as you resuscitate a child, the concept of ROSE comes. You optimize the fluid, probably use a stabilization method, and as soon as required, you might evacuate the child. Sometimes they self-evacuate, and sometimes you might have to use albumin with diuretics, all of these things. But after initial stabilization, you should all be very, very cautious about the fluid balance. More the fluid balance, more is the risk that the child will be requiring significant number of days for mechanical ventilation. So this is one of the study which was done in the PGI, and this was a sedation study which I am telling you that how does sedation vary, and if you use a good sedation scale and if you use an interrupted sedation scale, which we are going to talk next, said every unit should have some method where if the patient is stable every single day, what we call is it is called as sedation window. So every unit should have a sedation window and see how my child is, and if is the child good enough to go under a what it is called as spontaneous like awakening. Every day you have to give him a awakening trial, and if he is awakened, he is better, then probably he might, whether he is fitting for a spontaneous breathing trial or not. So this was one of the study, and which did tell that if you use a continuous sedation, you can see the number of mechanical ventilation days. It was around 10.3 plus minus 8.4 days, and this was around 7.1 days, which was significantly different between the two, obviously the intermittent and the continuous group. So what I want to first highlight is initial 72 hours or maybe first 3 to 5 days, apart from what we do routinely, which we give the standard care, you should optimally look at the fluid balance, and also you should think about whether should I stop the sedation, whether we should see that my child is getting better or not, is it fitting into my timeline, and whether we should now think about probably obviously an spontaneous breathing trial. So the things have changed after 2005 or 2010, where they have put that what is called as SBT, spontaneous breathing trial. You give a sedation window, you think about an SBT, and if everything is fine, you should think about ERT, that is called as extubation readiness trial. So that is very, very important. So every unit should think about it. Now the second point, which is very important, is which I told you, is there a method that can we wean this child, or is he ready for weaning? So the first thing which is very important is that I want to know whether my objective, there will be some criteria which you should be fitting. So few of the objective criteria are, so the most important criteria is whether the patient is having PF ratio of around 150 to 200. It should be better. You don't want less than 150. That is the most important thing. Your FiO2 requirement should not be more than 40 to 50%. Ideally, it should be reducing over a period of time. And I would prefer around 40%. And I would also prefer a PF ratio of around more than 200. And a PEEP requirement of 5 or below. The patient should be on minimal hemodynamic support, or probably noradrenaline of less than 0.05 or an adrenaline of less than 0.05. There should be adequate mental status where you should have a good cough reflex. Your GCS should be more than 8, and you should be able to control your oral secretions or take care of the oral secretions. Preferably, I would not want any child to have persistent signs of septicemia, or probably a new onset of sepsis, which is coming. And the most important thing, whatever you have intubated the child for, that resolution should be there. So these are the most important thing. And subjective criteria I have already put. So every child, again, you should have this kind of box in your chart, and you should think that whether my patient can go under a weaning readiness. That is done by nurses and respiratory therapists in West. But in our country, I think we have to discuss this in daily rounds, whether we can do this or not. So that is very, very important. It has been proven that if you think every 12 hours, whether my patient is ready for weaning or not, it reduces your number of mechanical ventilation days. So this is very important point, which is there. So there are a number of techniques of weaning, and it is all about the unit, how you are comfortable with, whatever unit you are getting trained into. The most important thing which will be there will be, I'm not talking about that the other methods which are already there in some of the ventilator, where you use them in a way they can self probably allow the patient to wean. That is called as an adaptive support ventilation, but we are not talking about that. We are thinking about in the lines where the patient is more than 24 hours mechanically ventilated. There you are putting the patient probably on 2 or 3 methods, which are the commonest methods is either it is pressure support augmented method of doing a weaning, or you are doing a CPAP method, or you are doing a TPs methods. There have been multiple trials in pediatrics, and I am going to put a last paper which has come in 2023, where what they have told is that how you can do. But there were a lot of controversies initially, where there was some group which was supporting that the small children have a very poor small airway and their resistance is very high. So you need some pressure to support that airway collapse, which can happen once they are breathing against a certain resistance. So you have to provide an adequate support depending on the size of the ET tube. So that was one of the method. But now then the group came which told that the patients who are difficult to get extubated, which are called as high risk patients, again we are going to put the number of patients who are what is called as high risk. There probably they are thinking that the CPAP method is very good and you should not give any pressure support, because they feel if you give a pressure support to such kind of patients, the failure of extubation is very high in such patients. So there have been number of again retrospective case series which are telling, or maybe retrospective papers which tell that. And there is one group which supports CPAP. The most important thing is we should know and we should be comfortable with any one of the method. It is some of the times you might use all the 3 methods in a given patient. Sometimes you can use just a single method and extubate a child. So that is very important. So there are 3 methods which we are going to discuss again in the next slide. And we have already discussed that we should think about daily SBT trial and extubation readiness trial. We don't promote a lot of sprinting. Sprinting we can discuss at the end of the day. Okay. So most commonly, what is an SBT? We are again telling you that it is how a patient initiate a breath on the ventilator. You are going to reduce the number of the rates of the patient. Like suppose you have started on 30, maybe you can make it 25, maybe you can make it 20. But at the same time, first of all, you have to reduce the PEEP to around 6 and less than 6. And your FiO2 should come down to 0.5 or 0.4. And then once your patient is stable for next 12 hours, and you feel all other parameters are getting better, then you should think about giving a patient an SBT trial. So which is either you put the patient directly on a pressure support method, like where you will only provide a certain PEEP. Above that, you will put a pressure support. Commonly, the pressure support is dependent upon the size of the ET tube. It may range from around pressure support of around 5 to 10. So commonly lesser the ET size, the more is the pressure support you provide. So suppose you have a ET size of 3 to 4, you will provide around pressure support above PEEP of around 10. Okay, 10 to 12. So that's how you do. And you have to see how long you want to do a SBT. Commonly in SBT around the world, now there are dictums that if your patient is of pneumonia, you put a patient on a SBT trial. He is not on any hemodynamic support. The patient is on minimum FiO2. The pressures have come down. Your oxygenation index has improved. So you will give them a trial of around 30 to 120 minutes. And then if there are peri-extubation protocols you have followed, probably you can even extubate as early as if the patient is even past 1 SBT. So suppose if your patient has not passed 1 spontaneous breathing trial, you have to see what was the cause, what made the patient that he is failing an SBT. Are we too early, or there are other things which are coming up? Suppose there is a patient who has now developed a healthcare associated infection, or probably there was significant dysynchrony which was not allowing the patient to have a good SBT. So you have to rethink and give a trial again after 12 hours to 24 hours. So every unit plans it that way. Okay, suppose you have given a SBT trial in the morning, preferably when all of us are around in a given unit. And if they have passed, even after 30 to 120 minutes after passing, you can think about extubating if other parameters are okay. So what is an extubation readiness trial? That's what it is. If you have passed an SPT on a minimal ventilator settings, probably you can mimic the experience once extubated. So almost it is like same. So already spoken about the SBT. This current paper which has come with the guidelines for 2022 or 2023 just where they tell that SBT is good enough for 30 to 120 minutes. You don't want to exhaust them. It is very clear that there is no advantage above 90 to 120 minutes of giving an SBT. So there is no point that you prolong an SBT, because most of these patients get exhausted and it doesn't help over a period of time. So normally a patient successfully extubated if they have tolerated an SBT, 70% number. And if you provide them with a non-invasive respiratory support after the extubation, sometimes this number goes very up, significantly up. So what is your assessment during SBT? It is a very, very important thing. First of all, if you are doing an SBT, I would prefer that it will be in morning time. You should be around. You should be carefully around the bedside of the patient. You should not be having any significant work that your patient is sick. You are going to manage that also, and then you are going to give an SBT trial also. And if you are going to do so, your unit should have a very good nurse who can understand all these points, whatever is written in this chart. And if there is any hiccups, they should let you know immediately, because as told, we don't want a patient to have again go up on the mechanical ventilator part or develop some collapse, or sometimes even if they can self-extubate them because your sedation has come down, they can have an increased risk of reintubation, and more the chances of reintubation, more is the chance of morbidity and mortality in your patient. So very important, once you look at the oxygenation and the ventilation during an SBT, preferably I would suggest that SpO2 should always be more than 95% with an FiO2 of around 0.4. That is tidal volume more than 6 ml per kg with almost minimal to no support. We have discussed what is minimal to no support. And PaCO2 preferably less than 45 to 50. And there should not be more than increase of 5 to 10 during an SBT. Child should be looking very, like he should not be anxious. He should not be sweating. He should not have significant change in the heart rate and respiratory rate. So if there is what is significant, if your patient is having more than 20 increase in the heart rate or more than 5 increase in the respiratory rate, when you are giving an SBT, child is looking anxious, tachycardic, that means probably you need to find why the child is not able to perform an SBT, and you to maybe stop and correct that factor and again give the SBT. It can be very simple thing sometimes, like a patient of LGBS, उसका हाथ कहीं फंस गया है, उसको कभी ठीक से suction नहीं हुआ है, maybe उसकी position ठीक नहीं है, and it can be a patient who is developing a collapse and you are continuing the SBT, that can also happen. So you have to be very vigilant during this process. The blood pressure should be fine. I told you with the minimal support or maybe with no support. Your GCS should be more than 8. The most important thing apart from GCS is how do you handle your oral secretions? What is your cough reflex? And how do you are how you are able to clear your secretions, which is the most important thing for a patient who is of obviously central nervous system involvement. So in every patient, all of these criteria, they should be fulfilling. It is not that 1 or 2 criteria, if they are not fulfilling, it is okay. I think preferably they should be fulfilling. Now, there have been a lot of efforts which are put on the blood gases. Let me tell you that blood gases may be important in certain patients, but it is not always correct. There have been number of papers which tell that if you go for an ideal blood gas around the spontaneous breathing trial or maybe an extubation trial, the number of mechanical ventilation days increases. So that's why multiple clinical papers are there where they are using artificial intelligence. They are using a lot of software details from the ventilators. But still, sometimes most of the papers tell that if you're a good clinician with looking at these kind of details, which we are speaking right now, they are as good as probably using any other software or the method to extubate a child. Okay, so there have been no significant difference between the 30 minutes and the 120-minute SBT trial. And as I have already told you, there is no point of prolonging an SBT. It can lead to worsening of gas exchange. It can cause you fatigue, and it can lead to significant amount of hemodynamic instability also. So extreme exhaustion should not be allowed during SBT. Okay, so methods of SBT, I think we discussed that there is a pressure support ventilation, CPAP and TPs. But the most important thing is I told you that there were initial papers which used to tell that depending on the ET tube size, you can use this minimal support. But now there are more and more papers which tell that you can use probably no pressure support with CPAP or sometimes minimal pressure support with a CPAP. So that means something above PEEP, maybe as low as 5, and preferably a pressure support of 0 and a PEEP of 5, which makes it CPAP, or a PEEP of 4, or depending on the age, 3, 4, 5. TPs, there are not number of papers which tell, but some of the units practice that they put it on the CPAP 30 minutes. If they tolerate it well, they use a TPs of 20-30 minutes. All is okay. They think about extubating a child or maybe liberating them from the mechanical ventilation. Okay. So this is what we discussed. Now, which method to use? There have been a number of studies. no set criteria, whatever you are comfortable. I would suggest you, we still use pressure support above augmented methods, which we are using in our unit, and we are like having almost an reintubation rate of 5 to 7%, I think, which is acceptable. Anything around 5% is fine. So recommendations for terminating an SBT. This is a very, very important method. You should all know that the respiratory increase as per the age, and we discussed that if it is more than 5, there is any increase in significant amount of heart rate and hemodynamic instability, your work of breathing is not looking good, you are using a lot of accessory muscles, the patient is looking anxious, and patient is uncomfortable, patient is having asynchrony, probably it is time that we should probably recheck and terminate the SBT. So what is an SBT failure? So it is very important that if there is an SBT failure, you should always document in your notes that why the patient has failed in SBT and whether you need to increase the support, what was the cause according to you. And it can, I've already told you, it can be very simple sometimes that your patient was not in the right sedation scale. Maybe the patient is having some pain in the cannula. Maybe his position is not correct. Maybe there is an ongoing sepsis and we thought that no, the child is okay. So we have to correct that cause. And once you have corrected that cause, then only you should again give an SBT preferably. Okay. So this was the third step, which I told you, which is again very, very important, which we are going to discuss, is the peri-extubation period. So the second part of my lection was that you should have a protocolized way of giving an SBT, and then you can think about and whether the patient is ready for ERT. So you should have an early SBT and a daily ERT thinking in the patient. And the third point which comes around is the peri-extubation. So peri-extubation, there are a number of methods. There is a clinical method, which we have already discussed. That these are the things which we are going to discuss in the round. There have been number of indices which are there and which have been done by predominantly Neweth, who is one of the research scientists who is interested in doing all these things. But if you look at his own paper in 2020 in respiratory care, there are a number of methods, that is RSBI, crop index. There are a number of things which he have written, but at the end he himself probably has written in a commentary that all of these are good on paper, but there have been no amount significant research which is proven that once you only follow these numbers and you can extubate a given child. So probably it is good for adults, but I would still put that clinical judgment remains far, far important in pediatric population in ICU, and these numbers may help you, but they may not guide you for extubating a given patient. So extubation may fail. That is very common. We have already discussed that 5% of the patients may have extubation failure. So my important point will be, how do you minimize these patients and how do you make it smooth? So this was one of the papers, I think, which you might have seen also, and you might have seen you might have read in the critical care medicine. And I think Dr. Arun Barnwal from PGI also has done a lot of research in this. And there are 2-3 papers which they have published, and where the 2 important things which they have highlighted is, if you want to extubate a child who has been on mechanical ventilator for more than 24 hours, or the patient who has infant, or the length of mechanical ventilation in these patients have been preferably more than 24 hours. What they have done is they've used a low dose dexamethasone or a high dose dexamethasone. And prior to extubation, the timing, it is important. So what they have told is, if you want to extubate a given patient, the most important thing will be the timing of dexamethasone and then the dose of dexamethasone. So timing is preferably they want at least 2 to 3 doses before you extubate a child. So at least they tell 6 hours. But in a new paper, they have highlighted that at least 2 to 3 doses, if they have gone, it will be very good. And they have quoted the dose as high as 0.5 mg per kg. In Indian scenarios, the West population preferably still uses leak test first. And in the leak test, they look at the leak percentage of more than 20% on a pressure of less than 25, which is on only a patient which has a cuffed ET tube. If you have a non-cuffed ET tube, then you cannot use these numbers. So you should have a leak of more than 20%, which is again important, on a pressure of less than 25 centimeter H2O inspiratory pressure. Then only you can think that the upper airway obstruction will not be there. There are new ultrasound guidelines which are also there in pediatric population, where before extubating you take the diameter, which is a very complex. I don't know if all of you are doing, but it is like we have not tried in our unit. But while I was a senior resident, Dr. Madhu was doing it, and we had a hard time doing it. But once he was able to do, the 0.8 millimeter on the either side of the tube, if it is there, the column, then we were preferably thinking that this was the number which, if we is there, we can probably extubate even without steroids. But still, in Indian scenario where there are multiple manipulations, where a number of intubation rates sometimes are very high, their fluid balance is very high, preferably they are septic, they are on prolonged mechanical ventilation, we prefer using dexamethasone, preferably 0.5 mg per kg, 2 to 3 days before, 2 to 3 doses before extubating a given patient. And there have been no significant amount of disadvantages. They have been quoted as hyperglycemia, increased risk of healthcare associated infections, but still, the Indian papers in our scenario suggest that in a given scenario, we should do this very often. And this can definitely help you preventing the reintubations. So this was again 24 hours before, 24 hours versus 6 hours before extubating a patient. This is a randomized control trial, which I was talking about, and where they have given 6 doses versus 3 doses. And as highlighted, I have already told you that they have told that 24 hours is preferable, and with total 6 doses, 4 doses before and 2 doses after extubating a given patient. So again, there are multiple papers which tell that if your patient is significantly sedated, it is not a good thing that your sedation score has to go down. Your patient should be more awake, active, alert, and on ventilator. Then you can think about probably extubating a patient. So dexmedetomidine has been used in peri-extubation care a lot. We see a lot of traumatic brain injury patients in our unit, and we don't use a lot of all these agents. We use simple midazolam and fentanyl still, and we are quite okay using midazolam, fentanyl, and extubating such kind of patients if they fit our criteria. So in a units where they have a lot of cardiac patients, or maybe patients who are on long term on ventilator, and you want to change them, if they are using a lot of midazolam and fentanyl over a period of more than 7 days, because of the withdrawal symptoms, it is probably time to change to dexmedetomidine and help you better care in the peri-extubation period and extubate such given patients. Okay, so probably the most important thing will be in your scenario, dexamethasone use that you have to think in this part of peri-extubation period. You have to take care of other things which we are going to talk next, which is the post-extubation care, which is most of the people ask, if you are going to extubate a child, what you are going to do, whether you are going to put on oxygen, whether you are going to put on high flow, whether you are going to use a CPAP, and what are the ideal things, what we can do to prevent such. So NIV has definitely helped in peri-extubation and post-extubation care. And there are a number of, again, papers from JAMA and from Indian studies where now they have shown that the reintubation rate has gone down to less than 10% once you extubate a child who has passed an SBT, who has successfully passed all the criteria for ERT. So my important part will be that if the patient has less than 1 year, if the patient is on prolonged ventilation for more than 7 days, if the patient has any airway anomaly, if the patient is not maintaining a regular oxygen after the extubation, and if the patient is having syndrome, these are some of the high risk patients whom you should not even think about putting them on oxygen. You should directly put them on either high flow nasal cannula, and if the baby is less than 1 year, you should put them on CPAP. And along with that, you should have a very significant smooth recipe, which is around the peri-extubation period. There should be de-evacuation or the minimum fluid balance, which is there. We prefer keeping a negative fluid balance or zero balance. And there is no technique which is superior than one another, that you use a CPAP, TPs, and dexamethasone in given children. Then you keep ready your high flow nasal cannula, and given set of patients, you put them directly on high flow nasal cannula as soon as you extubate them. Okay. So if nothing works, that is the most important thing which I tell them is always ask your seniors or maybe your bosses. They are the best people. They can usually guide them, and most of the time they are always right. Most of the time. So they are right by around 93% sometimes in the given studies. If your patient has definitely, you want them there should be less failure, you should always make a checklist, and you should look at the conditions which can create problems. Lot of times significant amount of sedation. How do you taper? Do we need to give something which doesn't cause withdrawal? You should look at potassium very carefully. You should look at magnesium. You should look at phosphate if they are on prolonged mechanical ventilation. Some of these patients can also develop critical illness weakness, which is again a very important part that has to be taken care of. cardiac function is very important because many of these patients who have myocarditis or maybe an associated LCOS, low cardiac output, these are the patients who may continue require some sort of afterload reduction in form of maybe milrinone or NVAS or multiple agents. So you may extubate, but you may continue some support. So that is very important that your cardiac functions are good. Many of these patients, sometimes before extubating, you would like to put them on TPs for some time and see, because patients who are on pressure support or on some PEEP, they can also give you an afterload reduction. So as soon as you put them on TPs, that afterload reduction will reduce and the patient may again have some sort of cardiac dysfunction, which becomes evident. So be very careful. Nutrition status has to be obviously good and you have to maintain that nutrition status. Patients who are malnourished, who are in a period in ICU, they tend to fail more. Tend to have more failures. So my extubation checklist will be the most important thing. Has my primary illness resolved or not? Is it improving? Is there any fresh onset of fever spikes, whether they are there or not? Any suspicion of ventilator associated event in last 24 hours? What is the fluid balance in last 72 hours? How are my electrolytes? May not be important for every patient, but yes, for some patients it is important. What is my cardiac function? Whether the patient has passed in a spontaneous breathing trial, whether it was a simple weaning means you have tried first time SBT and it is fine. Difficult is more than 3 times failure, and prolonged weaning is more than 14 days of requirement of a weaning plan. Okay. So depending on that, you might have to change the things you do. Simple, obviously weaning doesn't require a lot of other things, but in a difficult weaning, you need to see why your patient is failing an SBT. And in a prolonged weaning, it is completely different. Maybe you can discuss at the end of the class. So whether it is a syndromic baby, whether steroids have been given or not, what is my leak test? Now leak test, I was just discussing before this class to the Parag sir. So leak test, we do use it. All of us probably are using it in the patients who are having endotracheal tube, which is cuffed, and you see the pressures and see whether there is any 20% leak after deflating the tube. But again, alone leak test may not be helpful. There are again number of papers which tell even if the leak is around 10%, if there are other criteria which are okay, and if you have given them probably in steroids before 6 hours, or maybe at the time of extubating 1 hour, 2 hour before, even it is good enough. So only leak test it is failing, then it is not that you may not extubate a patient. But if this patient is an infant, this patient has got multiple airway manipulations, this patient has been on prolonged ventilation for more than 7 days, then probably I will wait for a day and get my steroids going, and then only I'll extubate such children. If the patients are on prior extubation failure, then I think we need to have all the ticks there, then only we can extubate a child. And we should consider an NIV in high risk cases. What are high risk cases? These are young age patients. These are patients on prolonged ventilation for more than 14 days with a long-term illness, myocardial dysfunction, and probably with upper airway anomalies, or they have previously failed an extubation. I think these are the patients who should be given an immediate probably in high flow nasal cannula or a non-invasive respiratory support by maybe a BiPAP or other methods as required in these patients. So that was about, but I ended this presentation early because I wanted to discuss most of the points with you, that whether now you want to ask anything significant, then we can discuss over a 1 point at a time. And how do you go about extubation in your unit? That will be very helpful.
Good, Ankit. Thank you. So, meanwhile, they are asking question. Have you tried TP's kind of a spontaneous breathing trial anytime? Because when we were in PGIB, we used to do it. Do you like it or?
So as I have highlighted, so my unit is predominantly a traumatic, maybe a road trauma like RTAs, severe traumatic brain injuries, post-op neurological patients. We prefer them just giving a CPAP trial. And if they pass with other things which you have already discussed in a CNS patient with a good airway reflex, good cough reflex, and we don't give a TP's trial. So I would suggest a TP's trial in patients who have been on prolonged mechanical ventilation, like maybe a GBS patient. You want to see what are the kind of efforts they have. Once they have already been gradually weaned off the ventilation, then we can think about a TP's. I would give a TP's in a patient who has a myocardial dysfunction. just to see as soon as we put on TP, sometimes they can have an overt myocardial dysfunction, as giving a positive pressure ventilation always leads to a good some amount of afterload reduction. So that is one thing that I would suggest TPs. And in a new paper, which has come with the guidelines, probably in American Critical Care Medicine, probably this year or this 2-3 months only last, I was reading through that. These are all like objectionable things. Like there is no guarantee what you want to do. So there are very low quality evidence what you want to do. Whatever you prefer, you should be ready with that. This is what I am going to do. So there is a no given recipe. You should be comfortable. And it only comes sometimes with experience. And that's why probably I thought it is better sometimes that your seniors can predict. Like sometimes in PGI, Dr. Arun Bansal will predict, yes, extubate this child looks fine. And sometimes we used to think, okay, we'll give 1 day more, 2 day more. And so that's why sometimes experience matters here.
Second thing is when we talk
So
about.
do you also use TPs? Like, do you use TPs?
No, I don't use TPs, but in some setting where you are kind of a short of ventilator and you wanted to transcribe one ventilator to the other patient, that's point of a time we might have done it, but not like a TPs. You're absolutely right. Second thing is, do you try pressure support or CPAP?
Yeah, so that's what I told you, sir. So when we were being like taught in senior residency, I think you also must be remembering that we used to look at the ET size, and then we used to say that there is certain amount of pressure which is required for these airway tubings to remain probably open and do not cause a lot of resistance. So you need to give certain amount of pressure support above a PEEP. But there have been now number of papers which tell this is not the correct method. And probably there are people who tell that you can only make this pressure support as 0 and give them an adequate PEEP of, depending on the age, 3, 4, 5. And you can just wait for 30 minutes to 120 minutes. If they are doing okay, they can be extubated. But still, I do in my unit is, as I told you, we always give some amount of pressure support. Always. Yeah.
I'll just make a comment here, sir. Hello, Ankit, sir.
Yes.
Suman.
Yeah.
Suman,
Sir,
please.
when I'm doing my DNB Pediatric Critical Care, a 3 years program, so my colleague who has done the similar study on CPAP versus CPAP PS. So
Correct.
this had a patients of nearly 120 in each group, CPAP versus CPAP PS. So few things what we have found in the study was, so one is RSBI and crop index were not at all correlating with the failure or what do you call successful of an extubation. Number one, which we found, sir. Second, CPAP versus CPAP PS also did not made any difference in extubation outcomes. Like either CPAP, ones who are on CPAP and PS and CPAP, there is no difference in whether this child is getting failed extubation or this child is having successful extubation. It did not made any difference in both the groups. This is what we have observed, sir. Vishnu's ka study hai, sir. Parag, sir.
Yes. So now, इसमें और एक चीज है. If so, first of all, Dr. Ankit has clearly told there is no benefit of TPs, so don't try that. Another thing is CPAP or pressure support, whatever is comfortable, both are fine. Most of us gives little bit of pressure support, physiological pressure support, I would say. Third thing is, what do you feel about using SIMB, PSIMB mode with 10 reps? So let it be a child of a 10 years old, you're on 10 on 5 with 10 reps. Can you extubate from that?
Yeah, so that's what I was about to come to you, sir. So my patient, suppose like he is of community acquired pneumonia and patient is now doing better. All the things are fine. And you have given them a morning, you are thinking that I will give a SBT trial and see, but you come as our senior consultant and you just feel this is all okay. Some of the times we have been extubated on patients who are on 10 respiratory rate and they have otherwise their spontaneous rate of 15, 20. They are awake, their ETCO2s and their other parameters are fine, and they are having no evidence of sepsis. That can also be tried. But I would even caution people who are very young. I think we may follow a protocol, and that's why protocolized extubation has been found to be a way better thing in a unit, and what it doesn't create any confusion. That is the best part. So you, as you told, we are not in a crunch situation most of the time. Probably this can be done in a patients where there are a lot of COVID scenarios which are there. There were lack of ventilators, there were other things. But still, I think that is not the method which is commonly described in any textbook. But this does happen in a few of the centers where all other things are okay. And they might sometimes be right. And that's why I put ask your boss. So sometimes it's like Dhoni taking a decision and sometimes he's always correct.
So absolutely. So the crux of the story is you can start little bit of a pressure support where when there is no complex patient involved, ask your seniors. You can really extubate from the minimal rate and PSIV mode of ventilation. Because whenever at other center at sick kids, they never used to give a pressure support trial. They used to lower down the rate 510 and they used to extubate. All things are correct, but remember, when there is a child, as Dr. Ankit said, let it be you have a child with a myocarditis, you have a child with LGPS or neuropathy, myopathy, those kind of things. Make it sure that actually these are not the ways. This is actually make it sure that they don't go for a reintubation again. And one thing I wanted to tell you, which is I always tell other fellows, is the weaning. Why we do a weaning is to reduce the duration of ventilation. The importance of weaning is to reduce the duration of ventilation. And the assessment of extubation is to prevent the chances of reintubation. So both are directed towards the different goals. So make it sure you are actually concentrated on your goals while doing all those things.
Yes.
Good.
So more things are as you told. So there are two, I think, subgroup analysis which tell if the respiratory rate awake when you are telling that I want to extubate directly, but if the spontaneous breathing rate is less than 10 for any given patient, you should never extubate. Yeah. So that was one of the, I think, papers which you are quoting. That was probably a Canadian paper where they used to do it directly, but they have written few cautions that this should not be done if these are the things. Yes. So new things which I want to discuss with them is, sir, there have been a lot of papers who are on indices, where they've been on leak test, and which they might have thought why Dr. Ankit has not covered, this is a DNB class. But the problem is there have been no like clear evidence, and that might create a lot of confusion. And if you go by the numbers and by the leak test and other things, they are telling that you can prolong the mechanical ventilation. And you cannot go by ideal blood gas. There have been some papers which look at that, okay, this is not my PF ratio, which is not achieved. This is not the things which are achieved. That they have proven that the mechanical ventilation days are increasing, and which is not at all good because you are keeping the patient more. And we all know that what are the consequences of keeping a patient more on mechanical ventilation. Right. So as Sumant was telling, these indices sometimes in pediatrics are not very well read. And Neweth 2009, where he came with lot of indices, he himself has written a commentary in respiratory care, I think in 2020, and you can all read that paper. And I will also share one of the recent recommendation papers from American Respiratory Critical Care Medicine, where they have given 13 points in pediatric liberation of mechanical ventilation in pediatric patients. And most of these things, whatever I have spoken, have come from there only.
So adults use a lot of these indices, but the reason for using these indices are really different in the as compared to pediatrics and adults. In adults, most of the time you can anticipate the extubation failure, but in a pediatric, it's become different because of the different age group. But if you see, I was talking with Ankit, their care space ventilator, which is a new ventilator, they have a very good respirology kind of a system where there is a P 0.1 indices and there is a negative intrathoracic pressure, which tells how much actually pressure you can generate. So if you are generating a -6, -7, that means you have a really a good strength in the respiratory muscles, and you would be able to kind of take a nice breath after separation from the ventilator. Or you are going to the criteria where actually you have a very good respiratory drive and there is a chances of that you can start coming down on the ventilatory pressure. So both things are same thing with the P01, but it comes with a lot of things. It's dynamic, as Ankit said, dynamic, depends upon sedation, what is the cause of a ventilation, what kind of things you are using it, tubings and all other things. One thing in the spontaneous breathing trial, I wanted to tell you, if a child of a 3-4 kg weight, intubated with 4.5 sides of a tube, and you have a ventilatory tubings, don't try to keep these patients on not PSMV, pressure support or CPAP for pretty long time, because most of the time they have an entitled CO2 attached. So the dead space ventilation is so much that putting them on a CPAP and pressure support increases the work of breathing, and you'll never able to take a decision based on that. So these are the patients, like you can put a rate on the lower side, like 15, 10, keep them on the little bit of pressure. And if they are looking fine, just go ahead with the extubation rather than waiting on pressure support and CPAP for longer time. Yes, Ankit?
Yes, sir. And
specifically newborns, almost if you see most of the newborns, they don't recommend prolonged extubation, spontaneous breathing trial, putting them on and most of them use pressure support rather than putting on CPAP.
Correct. So one more thing, I think, sir, one of the I think fellows has put in the chat box is you need to always shift to pressure support control from volume guarantee mode before extubation. So it is not true, as the sir has told. You can reduce the respiratory rate. You can come down to maybe 7, 8, 10, and you can give some pressure support with the volume guarantee, and you can see how much tidal volume it is generating in their own breath. If they are generating more than 6 ml per kilo and your other criteria which you have discussed are fine, probably again you can extubate them immediately. There is no need to put every patient on a pressure support. And if you want to be sure, you can just do it before maybe 15, 20, 30 minutes. 30 minutes is enough and you can extubate them. Okay, or liberate them from ventilator by putting them on. Sometimes you don't want to extubate, but you can just disconnect the ventilator and put them on TPs. This is a patient who is neurologically abnormal. So that is different. So that's why the sir is telling the goal is different. One is to discontinue the ventilator and second is to remove the endotracheal tube. Both are different.
In a routinely, Dr. Ankit, do you give glycopyrrolate before extubation?
So we don't use normally. No.
So just wanted
But
to
the
tell
art
you
of extubating is very important, sir. If they, I think they have to be very clear, because whatever is written, as soon as the patients are in the peri-extubation period and you want to extubate them, many of the kids are very agitated. And you have to do it in a rush. You are not even ready with many of the things. So I think you should always have a bedside, like maybe an inhaled steroids ready. Before that, maybe you should do a good oral suctioning. You should be ready with an ET suction. You should do it. And with some positive pressure, you should take the ET tube out. Because if you are not doing it, sometimes the airway may suddenly collapse. And you should not irritate the child, because as soon as you extubate, they are really irritated for 2, 3, 5 minutes. So don't go by that. You should just calm them, and probably sometimes it is all okay. Okay. We use a lot of like adults paper fluticasone steroids. We sometimes use budesonide, and if required, if the Krupp score is very high, which is obviously if we feel it is very agitated and Krupp score is more than 8, then only we give adrenaline nebulization. But otherwise, we don't prefer using adrenaline nebulization in every child. And that's where the role of probably steroids come. That I think you also were part of that paper which Dr. Arun Banwal done. You were the senior resident. And then he came with another paper of high dose versus low dose. And you were part of the 6 dose versus 3 dose, I think. So
good. At this moment, as such, we are giving probably 6 to 12 hours before dose of a steroid, or most of the patients actually they somehow received steroid because they were on a little bit of a shock, hydrocortisone and all those things. So it's all our purpose most of the time. Second thing is somebody has used adrenaline. You clearly told, he has mentioned about how frequently. What about the adrenaline nebulizations? So again, yes, a lot of time because of the pressure, we keep them on a scheduled nebulization. But actually, as Ankit said, always assess the airway, see the Krupp score, and if you feel it is because of the edema, then use adrenaline nebulization. That's really one. So another very important question. You thinking about extubating any child? Am I audible?
yes, sir.
Am I audible now?
Yes.
So you're thinking about extubating. This is a common scenario all of us see. You are about to extubate one child, let it be in the next 24 hours. But in the night, 1 o'clock, he got extubated spontaneously. What would you do? Would you re-intubate him? He has actually kind of preponed his extubation by himself. Do you re-intubate, or you see for a few hours and then if he's not tolerating, then re-intubate?
Sir, as you told, these kind of accidental extubations are never good.
Yes.
Once you are meeting a criteria that in the early morning we are going to plan the extubation, I think I would check my high risk list and immediately put them on a non-invasive ventilation for some time if there are any high risk criteria, right? And if there are none, and if in doubt, any maybe 5%, 10% doubt, I think I will sit by the side of the patient and decide in 1 hour whether I need to re-intubate or not. Because more prolonged you do, sometimes it is not good. That's what happened very clearly. We do a lot of traumatic brain injury patients. We just keep on lingering on them. Then suddenly the phone will come, sir, this patient is hypoxic, this patient is not maintaining. Once you do an X-ray, their airway has completely collapsed. You are going for an bronchoscopy. So there is no point. So I think I would suggest if ever in doubt in night, I think it's better to re-intubate and keep them on mechanical ventilation for 6 hours again, rather than take that risk that the patient succumbs or becomes sick and then everybody is moving around in the early morning or this scenario is very common, as you are highlighting. So for a
Very,
probably
very
a
important.
fellow, if he can monitor for half an hour, 1 hour, and he can put on a non-invasive support and inform the whomsoever is the in charge also that I am doing this. And if the plan is same, I think we can observe. And if in doubt, I think it's better to re-intubate.
So
Ankit,
simple
sir.
thing is once the child is getting accidentally extubated, so don't convince yourself to keep this child extubated. If the child is immediate having workup breathing, please put the tube back. Always remember the whole concept of extubation is a planned extubation. There is no accidental extubation. We discussed plan. Even if it requires little bit of a 6 hours or 12 hours of more intubation, that's absolutely fine. But re-intubate them because it causes a lot of morbidity, aspiration chances, was Dr. Ankit has told. So simple thing, if you have really confident and you wanted to give 10, 15, 20 minutes, that's absolutely okay. But if the unit is in rush and things you feel he is not the one who actually you would extubate in the middle of the night, please put the tube back and get him on ventilator and let the things settle down. Somebody was asking question.
Name me, sir.
Suman.
Sir, my question is, how often you saw diaphragm muscle weakness or muscle weakness being the cause for an extubation failure? And do we have any specific, most of the times we try to see in ultrasound whether the diaphragm movement is well or not, or diaphragmatic thickness. How far you find this diaphragmatic weakness has been the cause, and how well you can, how is the best method would be clinically to look the diaphragmatic muscle weakness could be causing the extubation failure?
So very happy that you asked. I was thinking that you should bring this up, anyone, or I have written the point. So first of all, diaphragmatic weakness may start as early as 24 hours, right? So that is very important. So patients who are more than on 48 hours to 72 hours on mechanical ventilation, everybody will have some sort of diaphragmatic weakness, which will be there, which is done. I think you must be doing it in the VD by VT karke, the ratio. I think in the, are you doing it with the M mode? That what is the kind of
M mode only, sir.
Correct. So there are now papers which tell that use of ultrasound is very helpful for patients' extubation. I have not put it because I was not very comfortable that what are the things which we should look into it. But as I told you, whatever you say, still there are no methods apart from clinical and some whatever boxes we have made that which is superior. But I would want that there are some soft markers which alert you that, sir, these are the patients who you should not extubate or probably think further and do it. Like in patient, as you told on GBS. Now, all the criteria are okay, but his diaphragmatic weakness is significant. Okay. And still there is some paradoxical weakness. So probably these are the patients who should do a fluoroscopy and document there is significant diaphragmatic weakness. There are patients of diaphragmatic hernia. There are patients of post-op cardiac surgery who have a lot of diaphragmatic weakness. Okay. And there are patients of some anomalies which can have diaphragmatic weakness. So what I suggest is, if you document that there is diaphragmatic weakness and your SBT is okay, then you should not worry about diaphragmatic weakness a lot. But if your SBT is also getting, I have written you, suppose prolonged, if you have seen weaning. So these are the patients who will be on prolonged weaning. Okay. So these are the patients who require some techniques for diaphragmatic fixation or a better nutrition, better oxidants, better antioxidants, and probably some sprint weaning for making their diaphragm work. So that's why I've cut the sprinting method for normal cases. But these are special cases which you are talking about diaphragmatic weakness.
Not only GBS case, sir. We have seen few cases where there is a sick septic patients, a sick VAP
I told
patients.
you. So the patient, even on 24 hours, they can develop diaphragmatic weakness. Right? So that is like critical illness weakness. So that are different from diaphragmatic weakness, but diaphragmatic weakness can even come in 24, 48 hours. Okay. So these are the patients, again, you have to prove. Our even sonologists are not able to do. I have suspected in last 1 year, 2-3 patients, but even they are not very 100% sure whether it is not weakness is there or not. So they will ask me to do a fluoroscopy, or there is some other method where the patient is having spontaneous breathing and they would see that what is the kind of percussion, the movements they are seeing in the fluoroscopy.
You saw, sir, any patient, because most of the times, as I said, like
we've seen 2-3 cases.
Okay. You are diagnosed by fluoroscopy, sir.
We have done finally fluoroscopy because these are the patients who are on prolonged ventilation, and 2 of them I think were of GBS and 1 of them was of probably prolonged ventilation for traumatic brain injury. But there were jerky breathing continuously, there was seesaw breathing, and there was significant low tidal volume generation, even on minimal supports.
Okay, sir. Okay.
So did
But-
you do anything like probably there are things which we ask surgeons or CTVS people to help to, even I have seen in PGI some of the post-op cardiac patients, but they just tell that it is the gradual weaning which you have to continue. Like there are rarely we have done anything for the diaphragmatic weakness, like any interventions. Yes.
Because sir, yeah, sir, as I said, most of the times, even the radiologist or we convinced that because of the diaphragmatic injury, but specifically we have not done anything apart from increasing the nutrition or gradually weaning the patient
Exactly.
from. Yeah.
Exactly.
Yes, sir.
So when we are checking the excursion of a diaphragm, remember they are not attached to the mechanical ventilator. You have to disconnect the ventilator, then only check the excursion of a diaphragm. Lot of times it happens, like even if it is a CPAP, high flow, or NIV or mechanical ventilation, whenever you wanted to check the diaphragm, disconnect from the ventilator and then check the excursion. Otherwise it will come other way around. You're not able to check the depth of contraction.
But I think, sir, we would only do all these things once the patient is not having a simple weaning. Correct. If you
Yeah,
feel
yeah.
there are methods which are failing, you are not able to
Like-
find the
like
cause, then you should think about all of them.
Yeah, what we used to do, or what most of the, so you identify the diaphragm, you check the excursion, and then disconnect the ventilator for some time, let them take their breath, and then check the excursion. Because if it is a paradoxical also diaphragm, in mechanical ventilation it will look absolutely normal. Once you disconnect, then only you will be able to identify the paradoxical diaphragm.
Yes. And I think they should start looking at simple weaning patients, then they can find that these are the patients who are having difficult diaphragmatic exertions. Because I think sonology is more about more and more you see normal patients, then you can identify an abnormal patient. So I think they should learn that, plus they can learn this airway technique which Madhu was doing. I don't know how much practical application for every patient it may be, but it is a nice tool to look into.
Madhu is here, so probably we can ask him. He is in Hyderabad.
Okay.
Good. So
So any questions, sir, from all of them?
that's why we'll try to go through it. So you really told how to reduce the duration of ventilation, then probably how to start weaning, and what are the two things really important for weaning. Third thing is preparing them for extubation and assessing them for extubation so that the chances of reintubation are less. Why it is important, key assessment of extubation. And fifth thing is what are the soft pointers which helps you for kind of going through this journey. So really well covered. In a short way, just short, small things, like while we extubate them, how exactly you do? You just told us briefly. So however, like it's quite common in the unit that we are wanted to extubate the child and then he start fighting it down.
Yes,
So
yes.
you extubate them, or you just take you around, give them a little bit of intermittent sedation, and then they extubate. This is
No,
one
sir.
question.
So like that is one thing. So I prefer reaching hospital at 9. So I ask them to stop sedation by 8:30. Sit there in the ICU like only. Don't go around. And we know that most of these patients are ready and they become really agitated. Once there are older children, they can be talked and sometimes they even like listen to you. But we use sometimes strain in the hands like a boxers or something so that they don't immediately pull and they don't hurt themselves. We prefer using a micro cuff ET tube, which is quite helpful, which is I think you might be also knowing apart from the tubes. So they cause less injury to the vocal cords and the subglottic area. So that's what we use. And as soon as the nurse tells her this is agitated and all those things, I think we leave everything and we deflate them. And we immediately keep all the things ready, which are obviously ready even before the extubation. And we put them on immediately the nasal prong and remove the ET with some positive pressure ventilation. And after that, we just do a gentle oral suction and ask them to please leave them. And I prefer keeping, if I am okay, I keep a parent with me so that they can just calm the child, especially child if he is young, less than 5 years. That is one thing we do. And we also use sometimes if they are very agitated afterwards, after 30 minutes, 1 hour, a small painkiller dose or sometimes maybe a very low dose sedation like a pedicloryl to just keep them calm for some time.
Do you remove NG and OG also before extubation?
No, we don't remove NG. We don't do that. And all the protocols will tell you to keep 6 hours NBM, but being our patients, we keep it around like maybe one feed we skip. So 4 o'clock is feed we skip. 7 o'clock we start preparing all those things, 7, 8, and we extubate by 10. And once we are sure that all is okay before lunch, then we are happy and then we leave them. Yeah. So that's
But
what we do. And
before
1 o'clock we
extubation,
start feed.
you don't remove NG and OG before extubation, yes?
NG we don't remove. No, we keep it open.
Because, sometimes what happens we commonly, if it is a very stable, no neurological thing, sometimes we just remove it because there is a chance that we might have to start HFNC and they're irritated with the nasal tube also. So we take that call. But yes, if it is possible, try to keep an NG and OG. It's a really good point. And you have to remember before extubation, you have to do suctioning probably every 2 to 3 minutes also to keep the things ready. And a lot of these people said, like, while extubation, you give positive pressure or negative pressure when you are removing the tube.
Like the concept was Singhi sir and everything discussed in the route, it is not written in the books. But as you keep the positive pressure, you keep the airways from, like when you're removing, you can suddenly have a spasm and they may get probably negative pressure and collapse. So it is better that you keep them a gentle ambu and give it, take the tube out. Once they are coughing very vigorously, I don't prefer. So I just put the bag and just take it out. Yes.
So there is nothing like that. Some people said you keep a little bit of negative pressure so that you can suck out the secretion. Somebody said keep the lung. So there is nothing like that. Make it sure that when you are removing, he's having an adequate kind of a breath and just remove it, do oral section and put them on. Great.
And one more thing, sir, I prefer putting an IV cannula and removing the tubes if it is required before extubating. So suppose if I am sure that I don't require any central line, I would prefer that I would put 1 or 2 cannulas and remove the central line and all those things. So I don't want to do any hustle after once I have extubated a patient. I want to keep them very like cheerful, happy. If I want to remove catheter, I would not give him any pain. I would prefer. Yeah. If I'm in doubt, I will change the cannula. Yeah. I would want his things, maybe a book or maybe some music, whatever he wants. I would keep him really cheerful. Okay. Great. And that really helps. I will keep some balloons. I'll keep some things ready for him. And we put something in front of him to just keep him calm. And I ask them to bring a lot of things from his home, which can make him feel comfortable. Yeah. Because it is very difficult sometimes otherwise to keep these children. Yeah.
Any question from anyone? I think so. Chetan sir is also there. Chetan sir, you wanted to add something?
Hi, good evening, everyone. Sorry, I joined very late, just last few minutes.
No.
But from the look of it, it seems to be a very good discussion. I would definitely like to see the recording. Please do make it available.
Sure. You wanted to say?
No.
Any question? Yes, sir.
No, it's okay. I mean, as I've not heard the whole lecture, so
any soft point that you wanted to tell about extubation, what you do differently? Just
I think we follow almost the same thing what have been discussed. Yes. And yeah, so keeping the child calm and quiet, that is something which is important, so that if they are very agitated, then that becomes a little difficult. Sometimes we have to hurry things up. Apart from that, yeah, nothing much.
Almost, yes, you're right. We follow the same thing. One thing I wanted to tell all of the people who are listening, it's not like that. For extubation, you have to stop all the sedation. Somebody is doing double things. So it is not like that. For extubation, you have to stop all the sedation. You can. There are certain patients who are on sedation for since last 7 days, 5 days, 10 days. In that kind of a scenario, you can wean it down, keep them awake, and then extubate, and then wean it down, because a lot of kids you see sedation withdrawal also.
I think somebody is on double device. So can you please stop one device? Because I think voice is echoing. Thank you. So sir, I think just to highlight all the things which have been there in the most important thing for us as I think the intensivist, we should have a proper checklist for all such kind of things just to not miss anything. And I would prefer that we have put a lot of charts in our ICU for maybe SBT trial and extubation readiness trial, what it should be our extubation checklist. And there is no harm that you make every single time, even if you are knowing that this is a very boring process, because all this boring processes helps you. There can be few of the things which may not get ticked, but you don't want to tick 100% of the things, but at least you will know that these are the things which needs to be probably thought about once you even think of extubating them. I prefer doing it. And the most important thing is, if there is any ongoing infection or sepsis or any evidence you feel that this child is not looking good today morning, I think you just go by your gut feeling and you can delay it, as Parag sir told, even for 6 to 12 hours. That's okay. Like, we don't want to again put them back on mechanical ventilation for sure. Okay. So please go by your clinical feeling also sometimes, which may be helpful.
Good. So, any other questions? If it is not, I don't feel so. Any question? Alekhya, Vishnu, Lokesh.
No, sir. I think most of the doubts we have been covered.
So remember, this is a very important topic. They will ask you during the examination. Okay. There will be
Yes,
a lot of discussion on this weaning and extubation somehow. Okay. So
Okay,
that's good. Ankit,
Yes, sir.
thank you very much. Yeah. Thank you very
No,
much.
I would send you that paper. Please ask them to go through that. And there are at least 200 references. If they want to go in depth, I think they can go ahead. And there are things that they need to learn, probably what we might not learn, but you might have to learn over a period of time what you have spoken, diaphragmatic thickness. You want to know about the airway anatomy. All those things probably in coming time will be very, very helpful, because more of these patients will be referred to you. You will be at a unit which deals with difficult patient. There they all will be very, very helpful to all of you. But remember that basics have to be done right. Then only you can discuss all these things.
Ankit, if you don't mind, can we add you in our group so that you can keep on sharing anything is required?
I have a lot of papers I don't read, but I keep on downloading them. That I can give.
That would be good for the fellows. So I'll add you into the group.
And I'll send you that paper. Okay, sir. Yes.
Thanks. Thank you very much. Thanks, Ankit.
Everyone, and
Ankit
I'm
has
sorry.
taken a half-day leave to prepare for this.
Yeah,
and
I am
present-
sorry, but I had to rush through many of the points, because
No,
obviously
no.
as a working consultant, you can't give a lot of time, but whatever I could try, I have tried. Yeah.
Thanks, Ankit. Thank you very much.
Thank
And
you.
great. Take care. Okay.
Okay, sir.
I'll close
Thank
the
you.
meeting.
Thank you.
It's fine.